Thank you again for joining us for another webinar. And just before we get too far into it, if you have good sound and good video coming through, can you write your country or your city in the comments? Just lets us know that everything's working. Now, with these sorts of things, I'm always trying to think of what things are interesting to people, what things are useful. Obviously, I can't teach you an entire, course that might go on for 3 or 4 months that I would teach at home. But there's some things that come up all the time, questions that people ask again and again. And by far the most common question is, how do we change the vertical dimension? The way we leave dental school, we leave with the feeling that if we were to increase the vertical dimension in our patient, the patient will probably die. Every single person who leaves dental school afraid of increasing the vertical. Now, this is despite the fact that almost every set of dentures that you will ever make, which is a full mouth rehabilitation, you will increase the vertical dimension because the last set were worn. So despite the fact that we do this to almost every single denture patient, we tend to be terribly afraid of it. Now, I'm just going to put it right out there. Changing the vertical dimension is convenient, it is safe for the vast majority of patients, and your patient will not die. I just promise you that one. If you want to know how much you can increase the vertical dimension, when the patient can no longer swallow while they're drinking, it's too much. If you want to practice this right now, try and swallow with your mouth open. So open your mouth, swallow, it's impossible. So once you've increased the vertical dimension, the distance between the nose and the chin that much, that the patient can no longer swallow or eat easily, then it's too much. But there's a lot of tolerance in most people, particularly because in most of the ways I'm going to teach, you get a chance to test run or test drive this change. So it's not something that you do straight from, that you start treatment on the patient and next week you put in their final crowns and you've changed their vertical dimension. Wow, that's not true. Some people do that, but I'm not going to recommend it. You should test drive or to go through a temporary or a mock-up stage to make sure that the patient is comfortable. Now, I'm going to talk about different cases and when it's easy to increase the vertical dimension and when it is not. A lot of this depends on the type of wear the patient has, the pattern. Now, we can use all sorts of fancy terminology. We could use really boring classifications and type 1s and 2s, but I'm trying to make it very simple. The first pattern of wear I want to look at is where all the teeth are worn. So the front teeth are worn, the back teeth are worn, they're all worn. These cases have some difficulties because they are usually high force patients. So a lot of these patients have very large muscles and they grind forwards, backwards, sideways. So from a control of fracture, they're a difficult patient, but from a planning of treatment, they're quite straightforward. So the reason why they're straightforward is because they've lost vertical dimension all the way along. You can see here that the height from the upper molar gingiva to the lower molar gingiva, in a worn case, where the back teeth are worn, that height will decrease. Now, if there's wear on the front teeth, the height from the upper anterior gums to the lower anterior gums will also decrease. So we've got a decrease in height, gingiva to gingiva, at the back of the mouth and at the front of the mouth. It is very, very unlikely that this is from eruption. So in this case, we almost certainly have lost vertical dimension. The chin has become closer to the nose. Now, the reason why that's important, there's a theoretical and a practical stage to this. From a theoretical point of view, much increase in vertical dimension will relapse. So there have been people who've done lateral cephs on orthodontic patients, on rehabilitation patients, and actually measured the angles of the various bony landmarks that you would do for orthodontics. And they've found that quite often when you increase vertical dimension over a period of time, it will decrease, not from wear, but from relapse. So basically you jack the patient's mouth up and their muscles crush it back down again. So like all forms of orthodontics, there's a huge amount of relapse. That's a theoretical problem. Are there actual practical problems with the patient relapsing their vertical dimension? Well, they can be if you have implants, because the implants won't move like the teeth do. But in general, no. It's a theoretical problem. It's not a practical problem. Now, from a planning point of view, you need to remember that when you increase the height of the back teeth, the height or change at the front teeth is usually 2 to 3 times greater. It's very simple mathematics. You've got a hinge here, and then the back teeth are close to the hinge, the front teeth are further away. So if you add 1 millimetre at the second molar, it will probably be 2 to 3 millimetres at the central incisor. So now, when you have wear all the way across the arch from front to back, so wear everywhere, often the front teeth are worn much more than the back teeth, which works perfectly. You can then plan, you can take your impressions, you can take bite guard, face bows and everything, send it to the laboratory and go, just increase, and you can do the measurement from the front teeth or the back teeth. Now, so first type of patient, wear all the way from front to back, increasing the vertical dimension, very easy to plan or justify, or and very easy for the patient to cope with, because they have usually lost vertical dimension, not just had compensatory eruption. Now, the second pattern of wear I want to focus on is where only the front teeth are worn. So the back teeth are almost perfect, and this is a really common, it's a very common presentation, and you need to be very careful, because you can increase the vertical dimension in these patients and make your life convenient, and you can also make the patient look like a horse. So at the moment, all we're thinking about is functional and convenience, but in a moment we'll move on to aesthetics. So you can't just add length onto front teeth and make the patient look hideous just because it makes your life easy from a restorative point of view. So with front teeth only, the big issue is that we've lost height here at the front, but the height from gingival margin to gingival margin on the back teeth is exactly the same as it used to be. Now, the reason this is important is because often the front teeth have had compensatory eruption. So you've worn the front teeth, and as you've worn them down, the teeth have continued to erupt, and then you've worn them some more and they've continued to erupt. And so the gingival margins get closer, but the actual height of the patient's face hasn't changed. So the height from their nose to their chin is the same as it used to be. The distance, the amount of tooth showing when they smile is often the same as it used to be. So as they smile, the gingiva has come down closer to the smile line, but the incisal edges have stayed the same. These ones you have to be careful, because it's very difficult to increase vertical dimension without changing the length of the front teeth. So you can increase vertical dimension and then you make the patient look horsey. Not always, but sometimes. So this is one of those cases where it's often easy to increase the vertical dimension, but you need to make sure the aesthetics, how you increase it will be driven by the aesthetics, not by convenience. A lot of the advantage of increasing vertical dimension is that you don't have to cut the teeth as much. The teeth are already worn, and if you need to fit 2 millimetres of porcelain in there, you need to cut another 2 millimetres. So if the tooth is the full length, then you can cut 2 millimetres off easy. If you've already lost 3 or 4 millimetres of tooth and you cut another 2 millimetres, there's no tooth left. So increasing vertical dimension is quite commonly convenient for rehabilitations. And as long as it will look good, you should do it in most cases. So as we increase here, we will increase, in these cases, when we increase the vertical dimension at the anterior, we actually will increase the total face height. So from nose to chin will increase. So these patients are not patients where the vertical dimension has decreased and we're restoring it back to what it was. These are patients where the vertical dimension has stayed the same and we're increasing it for our own convenience. So the front teeth have moved together, but the overall skeletal base has stayed the same. Now, in most of the time, these patients are still fairly easy to increase the vertical dimension in. You know, the front tooth worn or a whole arch worn, both quite easy. Now, the ones where it's not so easy is the patient that has wear on the back teeth only. Now, these ones, it starts to get very difficult to know whether the face height has changed or whether it's the same. The problem is when the back teeth have worn and the front teeth are still the same length, you often are very close to the pulp on the back teeth. So it's very difficult to cut further. There's hardly any tooth. Back teeth are short to start with, so you can't cut a lot. And if you increase at the back, because that height is 3 times greater at the front, so if you have lost 1 millimetre on the lower and 1 millimetre on the upper, and you increase 2 millimetres, now the front teeth are sitting apart 4 to 6 millimetres. Now, if the front teeth are not worn and they look good and you jack them up that much, now you've got someone who looks like a horse. Okay, they have very long upper and lower teeth. It looks like someone with badly made dentures, or there was a certain cosmetic style that went around about 10 years ago where every patient looked a bit horsey. So it would remind you of that time. So back teeth only are quite difficult where you have wear. Now, the patient who has wear of the back teeth only, usually it almost always comes from reflux or acid, but most often it's reflux. So more common in men than women, because more men get reflux than women. And quite often it's an acidic wear, not parafunctional grinding. Front teeth are fine, back teeth are down to the dentine. That's a very common, very difficult cases to deal with. Sometimes those cases need segmental orthodontics. So you actually increase the vertical dimension of the back teeth, and then you pull the front teeth back together with orthodontic. That type of orthodontics is not that fun. Now, a lot of the vertical dimension determination actually comes from the lips. Now, it's not determining where to put the front teeth and where the vertical dimension is going to be is actually really simple. And it's so simple that it's difficult for people to comprehend because they want it to be more difficult, they want it to be more complicated, and they want it to be somehow mathematic, and it's not. So it is exactly the same as when you make dentures. When you make a denture, you put the upper front teeth where they look good, you put the lower front teeth where they look good, and then you make everything else fit. It's the position of the upper front teeth and the lower front teeth that determines your final vertical dimension in most cases. It's so simple. So if someone has worn down teeth and you can't see their teeth because they're hiding behind their lips, and you increase the length so that their teeth look good, you will increase the vertical dimension. That's just how it is, particularly on the lower tooth. And that will determine your final vertical dimension. It's simple. Don't try and make it more complex. Don't try and find a scientific measurement with a contraption that measures the eye and gives you angles and things and tries to tell you. It's just very simple. Put the lower teeth level with the lip. The upper teeth 1 millimetre above, level or slightly below the lip, wherever it looks good. And whatever you're left with, that's your vertical dimension. If something looks good, this is not scientific, but it's very important. If something looks good, it usually is. Now, the reason why this works is because if we have our upper incisor and our lower incisor level with the lips, now you might think, well, where does our freeway space come from? Where does that, once the lips touch and then there's a little bit more room for the teeth to touch? Well, it happens like this. Okay, we've just moved the lips together until they touch. When we move the lips together, because most people, the lower incisors sit slightly behind the upper incisors, they won't actually touch yet. So even though the incisal edges are level, they're not yet touching. The lips are touching, but the teeth are not. And then, to move the teeth together, we have to close a little bit more, so the lips are slightly compressed. So now, and because it's most people, the lower incisors sit behind, the lower jaw has to come up slightly further. So that's where your freeway. So if you sit the incisal edges roughly level with the lips or slightly below the upper lip, wherever it looks good, so you can go off average values. So with younger women, we want maybe 2 to 3 millimetres of tooth showing, depending on their lip length. Older people, we want maybe 1 millimetre of tooth showing. This is at rest, not when they're smiling. And maybe, very old men, we might say that we want -1 millimetre, so they don't show any tooth until they start to smile. However, realistically, you put it where it looks good. So it's just like a denture. Put the teeth where they look good. Now, as the teeth move, it does open up another area where we need to be careful with changing vertical dimension. So normally you can see over there, in a normal patient, the lower incisor sits just up and behind the upper incisor. That would be what you would call a class 1 position in orthodontic terms. Now, as you open the vertical dimension, the lower jaw goes down and back. So you're making the patient more class 2, increasing the overjet, decreasing the overbite, but you're definitely increasing the overjet. So you're making the patient more class 2. So this is a case where you have to be much more careful with your patients. As you close the bite up, then you make the patient more class 3. So as you close the bite, the lower jaw comes forward. So that's another aspect that you need to keep in mind. So the first thing we look at the pattern of wear. Some of those will tell you which cases are easy and which are difficult, but then start to look at the orthodontic class. Particularly be careful. Most of the time we're not closing the vertical dimension in most rehab patients or full arch patients. So most of the time we're increasing it because the teeth are worn, that's why we're fixing them, and because it's convenient for us. But we always need to remember that as we open it, it becomes more class 2, and as we close the bite, it becomes more class 3. That's really important because if the patient is class 2 to start with, it might be disguised by the wear of the teeth. So they may have started life with a giant overjet, and then as the teeth have worn down, it doesn't look like an overjet any longer. It looks like a normal class 1. Then you get a wax up done and you put a mock up in and you increase the vertical dimension 7 millimeters, thinking you'll get rid of the deep bite, and all of a sudden you have a massive overjet. Sometimes you just have to live with that, but that's just something to keep in mind. So class 2 patients, the more you open them, the worse their class 2 will look. I'm going to go through a couple of cases now just to show you some of the planning stages and then how we might talk to the laboratory about this. So this patient came to me. Now, she has negative 3 millimeters of tooth display when she's resting. So the way you do the resting photograph is you get the patient, you go, open your mouth, don't smile. So just drop your lower jaw. And you always have to demonstrate it. So drop your lower jaw. Otherwise, you say, open your mouth, and they go like this, and they do a big grimace or a snarl at you. So drop the lower jaw and take a photo. Now, for a lot of patients, the teeth are level or they're just showing, but some patients, the tooth is sitting way up under the lip. And so unless you put a perio probe, you don't know how far under the lip it is. You can also get some of these results with digital smile design techniques, and digital smile design techniques are really an extension of Frank Spear's facially generated treatment planning. And Frank Spear's facially generated treatment planning comes from, well, it's from original denture making techniques. So all of these techniques you think are very modern and trendy and sexy, like digital smile design and so on, really, it's just transferring denture techniques to the mouth. So we have a patient like this, and then we go, okay, how much longer do we want the teeth? So we start looking at the smile. Now this patient, she's got an exaggerated open mouth smile. She's not doing a normal smile. She's doing one of these ones. The patients do weird stuff when we try and take photos sometimes. So if you tried to make her teeth follow the lower lip curve, which is often what we're trying to do, it would look disastrous in this patient because she's not smiling naturally. So when you're doing your documentation, you need to be very careful to pay attention to what the patient is doing. Are they doing a normal smile, or are they doing a terribly postured smile? Because if you build your teeth to a postured smile, then it will look awful when you're finished. So in this case, this is actually a angle corrected photo. So it's very difficult to see in this because the top's cut off, but if you look very closely at the top of the screen, you probably can't see it. The photo has actually been rotated 2 degrees to get it level. I get that level off the patient's facial pictures. You can do it many ways. I'm not going to go into that today. You'll have to come to another webinar or come to one of my courses. We'll go through that. So we've corrected the level of the teeth, and I've just used, this is done in PowerPoint. You can do it in Keynote. You can do it in Photoshop if you want it to be 10 times more difficult. I used the circle shape just to give, you just stretch it out until it looks like a smile curve. Obviously not the top bit, we're not worried, but using the full circle shape gives us a smile curve that will follow the lower lip or where we think the smile should be. So in this case, I've just drawn in here using one of the drawing programs where I think a tooth should be. How much tooth? Now, you can see that the top bit I have drawn to what I would think is ideal tooth length. This bit up here will never show, so how pretty it looks up there, we don't really care. The only time you would care about that is some patients have a low smile, and then when you fix their teeth, suddenly they get a much bigger smile and it can catch you out. So unless you think the patient has got a forced lower smile, then we don't care so much about the gum line, okay? Now, we care a lot on Facebook or when we're showing off in lectures. We want it to look beautiful when the retractors are in, but really that is not patient-centered dentistry. That's dentistry we do for ourselves. We're making the gums look pretty for our own benefit, and the patient will never care because they'll never see them. Obviously, a patient who has a high smile line, that's completely different. So when we then look at transferring that rough tooth position to the retracted photo, you can see, yes, indeed, if I wanted to get ideal shape of tooth in there, I would have to add length to the end of the tooth. But because there's been compensation, so if you look at this line here at the top, you can see that the front teeth are the gums on the front teeth are very much lower than the canines. Now, the incisors are usually a little bit lower than the canines, but not usually that much. So we've had compensatory eruption here, that the patient has worn her front teeth and then the whole tooth, including the gum tissue, has dropped down. This is a tricky case to diagnose because if you look very carefully, the patient already also has altered passive eruption. So the patient has gingiva that has grown down over the enamel of the teeth. So normally as the tooth erupts, the gingiva stays put and the tooth comes down. That's normal eruption. But in altered passive eruption, the tooth comes down and the gum comes down with it. Now, the gum always looks slightly irritable because gum tissue will never, ever stick to enamel. Nothing sticks to enamel. It's like Teflon. So the gum tissue will always often have a little bit of inflammation. And if you get a perio probe, you can usually probe 3-4 millimeters underneath the gum tissue because the gum tissue is not attached to the enamel. So in this case, we can see that there is definitely wear on the front teeth and there's compensatory eruption. I did actually do gum surgery on this case. If the compensatory eruption had brought the tooth right down so the incisal edge was in the final position, you can't just add length on. You can't just, there's a thing called a Shimbashi measurement, which is from upper gingiva to lower gingiva, and it's kind of an observational thing that then people have used erroneously to as a guideline. I think it's like 17 to 21 millimeters is ideal. But someone who's had compensatory eruption, and their teeth have erupted altogether and worn off, if you increase them back to 21, they will look dreadful because their incisal edges were, even though the teeth were worn down, the incisal edges were still in the same position. So we've planned on this particular patient, if we go back, we've planned the upper incisal edge position. So we can measure that, but we can calibrate this image and get a little ruler, PNG image, one of the clear images, stretch it over there and then turn it sideways and work out exactly how many millimeters we've added on in the photo. We can also work out how many millimeters we've added, taken gingiva away. Now we can do exactly the same thing for the lower teeth. So we can look at these lower teeth and we can go, there's just a tiny bit showing and it should be maybe 1 millimeter of tooth showing all the way across there. So then we can go back to our retracted photo and go, we need to increase this to get everything up to the height of the tooth that we're showing. So if you imagine on this patient we've added maybe 3.5 millimeters to the length of her upper teeth, when you do that, that's not going to increase the vertical dimension 3.5 because the upper teeth sit outside the lower teeth, but it will definitely add thickness to the lingual. So it might, changing the upper teeth to the correct length might have increased the vertical dimension 1 millimeter. Then we're going to increase the length of the lower teeth, maybe 2.2 millimeters. That will definitely increase the vertical dimension by exactly 2.2 millimeters. So you can see that the increase of vertical dimension in this patient will probably end up being around about 3.5 millimeters. And it's entirely driven by putting the front teeth where they look good. And that's it. Now, can we increase the vertical dimension? Is this a safe patient? Patient has wear on the front teeth, not much on the back teeth. Yes, it's a safe patient. Is she really class 2 to start with? No, it's not. So this is a patient where it's very easy to increase vertical dimension with no particular risks. I'll go through another case. Now this, a lot of times when people talk about worn dentitions, this is what they mean. And this patient has really no great difficulty with anything in her mouth except the wear. So her teeth are nice. You can see she has generally a nice smile. She just doesn't show enough tooth anymore. And the teeth are looking quite translucent because they're so thin. What often happens with these patients, they wear the back out of their teeth until the enamel on the front is so thin, and then the enamel snaps off and their tooth suddenly looks much shorter. This lady hasn't got to this stage. One other thing we might want to look at is how much lip support there is. This is exactly the same as denture technology 101. Obviously, this lady, the lip on her case, if we pushed it out a little tiny bit more, it would still look good. So generally want that lip and the nose at about a right angle. In her case, I think the lip is maybe slightly less than, or slightly more than 90 degrees. So if we were to make her teeth slightly more bulky and push her lip forward a little bit, it might even look better. That's important because if we want to do minimal intervention restoring her teeth, it's nicer if we make the teeth a little bit bigger. Now, if we look at this patient's wear pattern, she has no wear on the back teeth. All the wear is on the inside of her upper front teeth. This image is really it's quite difficult to take photos of this in a full arch picture. It probably won't come through on the webinar. If you go to the replay, or we'll probably put the slides up in the Academy. So if you're a member of the Academy, you'll be able to get the slides and you can look at them in high definition. Please don't use the slides in your own lectures, okay? Because someone will tell me and then I'll think you're a knob. So we can see here that I've just planned a tooth image there. I hope that tooth image comes up on the screen. Roughly where I think it should be. Not a lot of length needed for this tooth. Now this patient, you have to be careful with adding length to teeth because this lady has quite a small smile, so she doesn't have a big open mouth smile. So you can't necessarily, maybe another patient you would add 4 millimeters onto her teeth or 5 millimeters because you really want to increase the display of teeth. She doesn't show a lot of tooth, but that's not because her teeth are short. She doesn't show a lot of tooth because her lip doesn't move a lot. Now these patients can be quite difficult because sometimes as you increase the length of the teeth, then they start to smile bigger and then the teeth still look too small. And that actually happened with this case. I measured all of this and I sent impressions and face bows and things to the technician and I said, add exactly 2.7 millimeters to this corner of this tooth, and I gave him all the lengths. If you do these all the way along and you calibrate them, then you can add in exactly all the lengths that the technician needs to add on. So we did all that and then we did a mock-up, and the mock-up looked great. But even though we added all this length on, now she's smiling bigger and it still doesn't look enough. So that's where you can get a little bit caught out by things like how much lip movement there is. So some people have lips that hardly move. So they smile and the lip only goes up 2 or 3 mils. Other people have hypermobile lips where at rest they're not showing any tooth at all, but when they do a full smile, they're showing their gums. And so you can't just use the same rule of where you put the incisor ledges for every patient. This is a thing known as judgment, okay? You need to put them where they look good. You can't, there's no rule, okay? There is a rule which is roughly from +2 millimeters to -1 at rest, but there will be people who fall outside of that, and they're the ones you never get caught out by the patients who are normal. The patients who are average, who are easy, they are easy to treat, and those patients are not going to give you problems. It's the patients who are the unusual patients, the ones with small smiles, with hypermobile lips, with lips that don't move, with maxillary excess where they show all their ginger. These are the patients that catch you out. This patient is a tricky one. When we started going through the planning, you could see that I've corrected her head tilt here. So I've put some lines in through her pupils and rotated the head. Okay, now this picture is dead straight. So this is with the patient's head perfectly straight. You can see that the smile is actually much higher on this side than that side. In fact, the entire maxilla is canted. So her entire upper jaw, including the bone, is tilted. Now, you aren't going to fix that short of maxillofacial surgery. So unless you're going to cut the jaw off and impact one side and graft the other side down and do titanium. And in the number of times that I would recommend that for a 63-year-old is fairly minimal. That's fairly invasive surgery. You always need to keep in your mind that maxillofacial surgery, every so many thousand down fractures of the maxilla, they lose one. The whole maxilla dies. I always keep that in my mind when I'm recommending, and that's just in general. Obviously, older patients, it's more risk than younger patients. So that's something I keep in mind whenever I think about largely invasive surgery. Is it worth the risk? So we can see here we've got a whole lot of problems. We've got the smile line goes downhill that way. The whole lips go that way. We can't make it all straight with the pupils and the floor, otherwise it will look unusual. So if we were to just put in a smile design that was straight, you can see here I've done normal digital smile design, put everything straight. These incisal edges are straight with the floor, and you can see that she's going to end up with massively long left teeth and really short right teeth. So this is what I mean by you can't use measurements, or you can't use rules, or you can't be unthinking. You actually have to use judgment. So in this particular case, I feel that we kind of got to juggle things around a little bit more and just go, you know what, maybe if I try and make her teeth straight, it will look awful. Maybe I've got to tilt her entire set of teeth slightly to make it blend in with her face. Keeping in mind that her head and her pupils are dead straight in these pictures. The other thing we obviously want to look at is how much gingiva is showing. So you can see here, you know, if we keep things straight, not only will the teeth on this side be really long and short on that side, okay, but the amount of gum tissue showing on this side will be much more than the other side. So sometimes you have to use a thing called judgment. That's where you just look at it and go, it doesn't look good. And then you have to know why it doesn't look good and then fix it. So quite often these cases can end up being a bit like dentures. With a denture, you do a try-in, and then you look at it and go, no, that looks awful, and you move all the teeth around in the wax denture and then until it looks good. And so many of these cases are like that. You make a set of temporaries, or you get a wax up done, and then you try it in and you go, oh, it looks awful. And then you get composite resin and you change the shape of the teeth until it looks good. Now, if you look online or on Facebook or on people selling courses, they will show you where they did a smile design and then the technician did it, and it always works perfect every time. Now, the reason it works perfect every time is because they're not showing the cases where it doesn't. So it's very easy to make something work all the time. Never show anyone the ones that don't work. I have done digital smile design in all many ways, and you never get it 100% of the time. So on easy cases like the last one I showed you, it's easy to get it fairly close. But on cases like this, often you're going to need to adjust your temporaries and so on, which is why you need to know what teeth look like. Actually, we were just setting up all the courses for next year, and we used to have an anterior course that was just veneers and crowns and composite resin. Now we've split that into two, and the first stage is composite resin, but in particular is shapes of teeth, because the more I teach, the more I realise that people don't actually know what the shape of the front tooth is. They sort of know it looks a bit blobby and whitish, okay, but where all the line angles and so on are exactly, it's quite common for people not to know that. They need to do waxing courses or mock-ups and so on. So shapes are very important. Now, I'm going to show you this case to go through. This case shows you some of the difficulties you have when you increase vertical dimension, and when you do that, you also change the bite. So aesthetically, we've made a huge improvement to this patient. Very difficult case. Now, once again, difficult cases are difficult. So we can see in this patient, he's missing teeth. And when you see the retracted photo, you'll see we've got wear, we've got teeth fractured, we've got things going on everywhere. The patient also has a gag reflex, which just for a bonus. And then the lower teeth, we've got teeth missing everywhere as well. So we don't have everywhere. Well, the planning starts exactly the same as everyone. So this photo is useless for planning because we can't see lips. So Sometimes people ask me for help when they're planning cases. If you show me pictures that are retracted when you want planning for rehabilitation and you don't have any smile photos, I can't help you. If your photos are not straight, I can't help you. If your photos are taken, it's very important when you take the retracted photos that the patient's head is not tilted back or forward, because if their head is tilted back, the curve of the upper teeth looks like a frown. And then if you planned on that, you would make the front teeth massively long like a duck, okay? It would be not like duck face, it would be duck teeth. If a duck had teeth, that's what it would look like. So lots of issues, okay? Now, when we go through this case, we're going to look at the lip and then we're going to decide, do we need to add length to the upper teeth to get them looking good? And in general, in this particular patient, no, we didn't. Just with these cases, often with these cases, there's a whole lot of basics that you have to go through, like you have to build up all these teeth, do some extractions, and do some core build-ups and so on, okay? And then we get to the front section. See, we've got some extractions going on there. Started doing temporaries, same on the lower teeth. Now notice this here, these front teeth are way too long. So when we look at him in the smile photos, he's showing too much lower teeth. That's because he's got no anterior contact. So the lower front teeth have erupted up until they hit the palate. So we need to shorten the upper teeth, up the lower front teeth, but notice how much wear there is on these back teeth. So the back teeth need to have the heights lifted, front teeth need to come down so that it looks like that. Okay, so by temporizing from a waxer, we leveled the front lower teeth and increased the height of the back teeth. Increasing the height of the back teeth will increase vertical dimension. In this particular case, what happened is he was posturing, because he'd lost all his teeth, he had learnt to posture his jaw forward about 7 or 8 millimeters, and because of the deep bite and the lack of teeth. So he looked a little bit class 1. And the moment we did this to him, his upper jaw opened up and then it went back. And then once he'd gone back, he got stuck in that position. He could no longer be recovered to his original position. So this is one of those tricky patients because he's class 2, deep bite. When we opened his bite, we made his class 2 worse, bigger overjet. To this day, he has no contact on his front teeth. So I can't get contact on his front teeth without cutting his lower mandible off and moving it forward, which we're not keen to do. In this particular case, because of money problems, because we're running out of money, I couldn't do as many teeth as I'd like, so I did a thing called a shortened dental arch. So then we started looking, okay, we've got temporaries on the lower and we've got temporaries on the upper. Does it look good? No, it doesn't. Too much lower tooth, not enough upper tooth. If you want to make someone look old, make their lower teeth long, upper teeth short. Makes people look old. So now be aware that when someone's had short lower teeth for a long time, when they bite together, their lip everts, okay, or it gets squashed down. So when you add the length on, sometimes they do actually do this for a while. They sit there with their lip down because they haven't learnt to hold their lip up to the normal height. So sometimes these patients, you increase the length of their tooth on the lower and they show too much, but then next week they don't because their lip has smoothed out. See this a lot with dentures too. Okay, I had a lady today who had dentures. Because the dentures are worn, she closes together too much and her lower chin comes way forward and she gets the creases down the corners of the mouth and her lip just looks weird, it pops forward. So in this case, now we're basically being a denture. We've turned them into temporaries. We don't like the temporaries, so now we're starting to add composite resin to change the shape of the temporaries. So this is why it's important to do dentures and to know the shape of teeth, because you can't change the teeth around if you don't know the shape of them. So we've added some length here, and we've got the lower teeth. We eventually got those lower temporaries where we wanted, so now we can prep the lower teeth. Going back to our temporaries, still the length that we wanted, and we go through the whole process. Now, just a few little tips and clinical stuff. Quite commonly, this was a pressed case with Emax. It's quite common for me to ask the technician to wax it up and then for me to go and have a look. So if you want to get good work with the technician, you need to go and check things, and you can go and look at the shapes of the teeth and go, yeah, that doesn't look good, or it does look good. It will also teach you about the lab, because in the lab, everything looks amazing. So A wax up like this looks great in the lab, but when you look at it in the mouth, you go, oh, that looks awful. So the lab is very forgiving, and it takes a long time to train the eye to see problems in the laboratory before it gets to the mouth. Once you can see it, you can also train your technician. Go through the whole bonding process. Okay, I'm going through this whole case because I want you to see what happened at the end. Bonding, I don't always use rubber dam to bond. I did in this case. Sometimes it's better, sometimes it's worse. And then we go through the upper temporaries. We had these to the length that we wanted. So now we've finalised the lower teeth, put the patient in temporaries, made sure they look good, finalised the lower teeth. Now we're finalising the upper teeth. So we're right here, what we're doing is relining around the gingiva with some flowable prior to taking impression for the mock-up. So when you make temporaries, you'll notice that quite often they get too thin around the gingival margin. So instead of trying to fix it afterwards, sometimes you can just put some flowable around the teeth, take an impression, and use that impression for your temporaries. So in this case, we took the temporaries off this side, prepped everything at the back, took a bite record at the back. Well, actually, we started over that side. Temporaries stayed on there. We took off the front teeth, took a bite record after we prepped, then prepped the side teeth, took a bite record, and then eventually took those temporaries off over there and took a bite record. So maintaining that bite all the way through as we removed the temporaries. Go through the impressions as usual. Okay, and then new set of temporaries. I've now worked out how to not get these bubbles. When you inject the bisacryl into your stents, you need to get the nozzle right down in the incisal edges and run all the way from one incisal edge to the other to fill it up, and then go and fill up the rest. If you try and fill up one tooth at a time, you always get bubbles. Okay. Preps came through, impressions, then cementing and so on. In this particular case, I've wrapped Teflon around the pontic of the bridge to cement it. Okay, continuing down the line, cementing everything there and checking the bite. Now I have contact on the back teeth. I've done a shortened dental arch. This sort of texturing was developed by me and the technician. So the technician and I went to the laboratory and sat down and I said, no, it's too smooth, you need to put some texture in. And we spent quite a bit of time working out how to grind the little lines into the teeth and then put glaze on it and then not fuse the glaze fully. So we run the glaze to a low temperature so it doesn't fully fuse, and then hand polish it to get more of a satin sheen on the things. So we've used bridges here. Whenever I can do a bridge, I will, because implants have high complication rates. Bridges have complication rates too, but bridges never deintegrate in 1 month, whereas implants can. Bridges never get infected in the first 3 months and take out all the adjacent bone and the soft tissue. Implants can. So if I'm restoring teeth anyway and I can do a bridge, I will do a bridge. The economics are better. The comfort for the patient is better. The convenience is better. If you're doing work like this, you should be able to prep. If you can't prep a tooth like this and avoid the pulp, I don't think you're much safer with a 2 centimetre long implant drill. Now you can see here we've increased the vertical dimension a lot, and what you probably can't see in this picture is that we've now made the patient more class 2. So you'll see it in the side pictures. So you can see I wasn't able to get completely rid of that. To get that completely level would have made the class 2 and the open bite worse. And more importantly, I would have exposed all the pulps in these teeth. So if I cut the teeth right down there, I would have exposed the pulps. Sometimes it's just not possible to get that sort of perfection. You can see from this side view though, how we've increased the overjet. So prior to doing this, the patient had contact on his front teeth. However, after increasing his vertical dimension, we've made him much more class 2. Now he has a big overjet between the front teeth. I can't fix it. Some people suggest in these cases you actually make them in their normal bite. So you just say bite together on your front teeth and then you make the rehabilitation in that position. The problem with that is then they're going to hit hard on their back teeth when they grind. So they're going to break their back teeth. Many people have lived very healthy lives with anterior open bites. In fact, anterior open bites are the best things for veneers ever. So, you know, just call it second molar guidance if you have second molars. Once again, seeing the overjet from here. Aesthetically, it looks pretty good now. We've lengthened the teeth. So it looks as good as we're going to get. The lower teeth display is probably still more than I would like, but he's posturing there. Short of cutting them all off and doing root canal therapy and crown lengthening, or extracting the 4 lower teeth and doing implants, there's no way that I could get them down. Now, always keep in mind there are other options. I could have extracted the 4 incisors, done 2 implants, and I've done a bridge further down. I'd have an even bigger overbite, overjet, and distance between the front teeth. I could have done orthodontics with temporary anchorage devices and pull the teeth out. So you can always get the teeth where you want. Sometimes you just got to decide that you're going to do it. In this particular case, I don't do it as much now as I did back then. But I was a bit confounded by the fact he had to drive a long way every time he had an appointment. And I was trying to get the dentistry done in a fairly short number of visits. Nowadays, I tend not to care about that. If they can't come to the visits, that's their problem, not mine. So we finished up, shortened dental arch. In the future, we'll add in some more implants there. You don't have to do your entire case all at once, but he's generally pretty happy. So there's some ideas for ways that we can plan, particularly changes in vertical dimension and which cases are good for changing vertical dimension, which ones are not, and then some of the processes that go into it, and how we have to also consider the aesthetics and the orthodontic class. So remember your orthodontic classes, remember the pattern of wear, and remember the aesthetics. Those 3 things together help determine our vertical dimension. Now, if you've been asking some questions, that's great. Gail will send them to me. If you haven't asked questions, it's a good time to do so. Okay. I have a question from Abay. Please relate the increase in vertical dimension with the TMJ. So I think the concern is that if you increase the vertical dimension, it will affect the temporomandibular joint. It really does. When you do these rehabilitations, because you remove all of the previous bite references, the patients often, their bite changes. Now, if you want to make sure all their muscles are relaxed and their jaw is in what you would call centric relation, then you should put them into some sort of deprogrammer for a certain amount of time until their bite is very stable. If you want to know more about this, then a really good resource is Michael Melker's. Go on to Ripe and look at some of his posts. He's got some very good posts on how you deprogram a patient into a stable, repeatable position. Increasing the vertical dimension will not give the patient temporomandibular joint problems in all but maybe 1 in 10,000 cases. It doesn't improve their temporomandibular, but it doesn't decrease it either. It's something you do and the patient basically gets used to it in a couple of days. It's really, I don't know why it becomes such a big deal, but it has. So, question from Jabba. How would you increase vertical dimension in edge-to-edge occlusion? In occlusion, upper anterior heavily worn and no posterior. So edge-to-edge, if someone's edge-to-edge to start with and you increase their vertical dimension, they'll become class 1. So they're a bit class 3, you increase the vertical dimension, now they're class 1. There are some patients who have significant wear and they're basically class 3. Class 3 patients get a lot of wear on their front teeth because they want to come forward. Or they have an anterior open bite with a reverse overjet and they got wear on the back teeth. Those patients, if you increase the vertical dimension, they look better. So class 2s look worse if you increase, but class 3s look better if you increase, unless they have a long face height, you know, the dolichofacial with a long face to start with, then don't increase them. How do you do it with upper anterior heavily worn? So heavily worn front teeth, you have to look at what I was telling you earlier. Can you increase it without it looking bad? So that goes back to aesthetics. If the upper front teeth are worn badly, you have to go back to aesthetics. Can you add length? Where do you need to put the incisal edge to look good? And then work out your vertical dimension increase from that. You can't just go, the teeth are worn, I'm going to put the length back because it might look awful. So the pattern of wear tells you which cases are easy, but it doesn't tell you whether to increase the vertical dimension. Increases in vertical dimension almost always driven by aesthetics and convenience. With no posterior teeth. So if you have no posterior teeth, build the front teeth up to their position with temporary crowns and then add back teeth in later. So either with a denture or with implants. So whatever way you're going to add back teeth in, you do that later. Jamie asks, what's your routine in assessing how much vertical dimension to increase by? I just spent an entire thing saying put the front teeth where they look good, and that's where it is. And I said it's very simple, and you don't measure anything. You just put the upper front teeth where they look good. You put the lower ones where they look good, and that's your vertical dimension. I can't say it any more simply. I can say it again, okay? The way you determine vertical dimension is you put the upper front teeth where they look good. You put the lower front teeth where they look good. In most cases, they've got worn teeth. So when you increase the length of their upper and lower front teeth, it will increase their vertical dimension by however much you need to for the teeth to fit. That's it. Okay, it's very simple. Don't make it more difficult. No, I don't use LVI. I tried that, it didn't work. No, you don't need to use a TENS. Okay, the only reason you should use a TENS is if you're really rich and you want to burn your money. But if you want to do that, just give your money to me. Come to some courses, I'll take it off you. Okay? At least you'll get some better value out. I have a TENS sitting in the cupboard that I haven't used for 9 years, so you can have that one if you like. The problem with the TENS is if you get a TENS machine and you use one of those electromyography machines, you can show that the TENS reduces the muscle activities of all the muscles, but what you can't show is that it has any clinical significance. Okay, you can show that it reduces the little lines on your K7 or your K9, whatever it is, okay? I have one of them in the cupboard too, you can have it. It shows the muscle activity on your electromyography readouts is decreasing when you TENS someone for ages and you get them in this downward forward position, but there's no correlation between that and improved clinical outcomes. I've done hundreds of rehabs. I did quite a few the LVI way, and I did quite a lot just normal old open it up on an articulator and centric relation way. There's no difference in the outcome, okay? The only difference is that centric relation way is more flexible. So for the patient who can't afford everything, you can do it in bits and pieces or in much more smaller segmental treatments, which means you're not as poor, okay? When your only option is you've got to do everything or you do nothing, then guess who ends up poor? Not the patient, you do, okay? Patients don't like it when you only have one option and it's $50,000. Golden ratio is a load of nonsense, okay? Golden proportions. Okay, yes, you can find all sorts of examples of golden proportions. Nice teeth don't fit into golden proportions. Golden proportions look nice, but they look a bit denture-y. So there's a whole range. Probably the best person on aesthetics, lecture on aesthetics I've ever seen is by an Italian guy called Luca. I think it's Luca Dolica. He's a oral design trained technician as well as a dentist. And he has a very beautiful lecture which shows that your teeth can be crooked and all sorts of things and look absolutely exquisitely beautiful as long as you pay attention to special things like central dominance and these sorts of things. So if you want some sophisticated aesthetics, go and listen to a lecture by him. Golden proportion looks good in some patients. It looks like a denture in a lot of people. How do you adjust the patient bite when the patients are in temps and also after the permanents go into the full mouth case? So when you put patient in temporaries, I generally adjust the bite with a leaf gauge, okay? I jack them up with a leaf gauge until they touch on one spot, usually on one back tooth, and I adjust that until it's not touching, and then I take one leaf out and I drop them down and I check where it's touching and I adjust that, and then I take one leaf out. And the reason why I do it like this is because it keeps everything perfectly balanced as you drop them down. If you just get to the patient and go chomp, 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 okay, the patient might be posturing off to one side like this, and then you adjust everything, and then they start moving over to the center, and then you've got to adjust everything on the other side, and it takes forever. So leaf gauge, jack them up till one tooth is touching, adjust that one spot, take out a leaf, drop them down bit by bit, and then once you finish dropping them down, they're perfectly even. With full mouth cases, you don't want to be doing massive adjustments, so think about why you've got big problems. But otherwise it's the same. If you're adjusting porcelain, it's the same. You jack them up with a leaf gauge until one tooth touches on the back, and then you adjust it a little bit, and then you drop them down and you adjust it on the next spot until the front teeth touch. David, considering bridges in rehabilitation, what is your opinion on double abutments and other multiple abutment situations? That's sort of a question. That's a question where I need a case. So when you start getting into quite specific questions like that, I need a particular case that you're showing me, going, what would I do here? And then I can go double abutments or not. Bridges obviously work best when there's one tooth at one end and one tooth at the other end, unless they're very, very long. As soon as you start getting pier abutments or double abutments, whichever tooth is the weakest tends to fail, because it's, I'm not going to go into those mechanics of why that happens right now, but generally if you have a long span bridge, whichever. Now, sometimes you have to accept that it's a compromise and one of those teeth will fail. Anyway, that question is too specific. You'll need to send me a case or post the case and go, what would you do here? This is from Callum. When putting a patient into a full mouth composite rehab and gradually transitioning into ceramic, is it worth making the posterior composite units all separate, or would you be splinting them? Okay, a lot of people try and do composite rehabs by using a stent. The short answer to that is it depends. It depends how long it will be. If it's going to be, 5 years, then you want to make all your composite resins individual. And I do it personally freehand. I can rehabilitate an entire upper and lower arch. It takes me, if I start at 8:30 in the morning, I'll be finished at about 3:30 in the afternoon. That's about 20 to 28 teeth. And I will do it freehand, but I have done this many times, so I can kind of see how much I need to add on to the teeth. I find that when I use stents, you get slightly more precision, but then you spend about 10 times longer fixing all the interproximal areas, because it's much harder to control the interproximal excess when you use a stent. I have tried using Enrique Guzman's technique of the clear stent with flowable, but the flowable chips a lot. And once again, you end up with a lot of excess you've got to clean up. So I found it easier just to do them one tooth at a time. You add length on and so on. It also teaches you a lot about occlusion, to build a case up freehand and then grind it into position and then fix up all the bits that don't look good, okay? So where are we going? Would you be splinting? I wouldn't splint them for long-term cases if you're doing a composite build-up, is the short answer. I think you get too much plaque, you end up with gingivitis. It's just really hard to control. It's not like temporaries where you can get big embrasures. If you're just doing composite over everything, if you're doing a more short-term, you'd be better off to put them into acrylic temporaries and then cement them with something like Duralon, which is a long-lasting temporary cement. This is from Rawl. With both jaw wear and the upper one, can you do the restorative only on the upper, assuming there is no issue lower, aesthetically speaking? Yes, as long as yes, you can, as long as the lower jaw is level. So if the arches are level, you can increase vertical dimension a little bit on the upper jaw, get it looking beautiful, and then in 2 years' time, you do the lower. If the jaws are not level, then you must level them, because you're going to make the upper teeth match the lower teeth. If the lower teeth are all wonky like this, then you have to make the upper teeth all wonky to match. You can hide it on the front, make the front look nice, but the occlusion of the upper teeth will look awful. So in those cases, you need to do some sort of mock-up over the teeth. So if it's short-term, I would just do a bisacryl mock-up like Luxatemp or ProTemp. You bond it straight over the top of the teeth. If it's long-term, then I would just, personally, I do a freehand composite. I can do, if you're just doing it to level the lower arch only, then just put it straight over the top of the amalgams and fillings and everything. Okay, last question. Matt, this is from Matt. You mentioned taking progressive bite records as you are removing the temps from the posterior. Can you please reiterate the significance of this with respect to achieving our ideal final occlusion? Yes, I can, but not today because time's up. I will talk about that in one of our future webinars. So make sure you're on the list to get sign-ups for the webinars and that you logged into the Academy so you can see the replays. Occlusion is something that, depending on whether you're in Australia, the best thing for that is the live patient rehab course that I run. Unfortunately, I think it's booked out for next year. Too bad, so sad. But you can join the waiting list for that. If you're not in Australia, I suppose you could come and you could go and send an email to Gail. She might be able to put you on a waiting list to actually just come and observe. Otherwise, I am going to do a series of lectures on more of the occlusion side of things in the future. So thanks for the questions. Thanks very much for listening and hope it was interesting for you. If it is, please tell everyone. Often we get people telling us afterwards they didn't know it was on. So if you know there's a webinar on, make sure you tell all your friends. And if you want to see the replay, you'll need to log into the Academy. Thank you very much.